You recorded now.
Great, thank you so much. So today's meeting agenda for the Electronic Health Information Advisory Group was posted on March 26, 2024 on dhcfp.nv.gov and at notice.nv.gov. So we'll move on to agenda item number 2, the roll call. So I'll start with the voting members. Dr. Eddie Ableser. Dr. Ableser, are you joined yet? Okay, we'll move on. Sarah Bradley.
I'm here.
Great, thank you. Eileen Cullen. Kathy Denauer.
This is Jerry Reeves. I'm here on behalf of Eileen Cullen.
Oh, I'm sorry, Jerry. Who are you here on behalf of?
On behalf of Eileen Cullen.
Oh, perfect. Thank you so much.
Kathy Denauer here.
Thank you, Kathy. Michael Gagnon.
I'm here. Thank you.
Thank you. Brooke Greenlee.
Hello, I'm here.
Hi, thank you. Ashley Jolke.
Present.
Thank you. Michael Kennedy.
Hello, I'm here.
Great, thank you. Dr. Christopher Lake. I think he was absent today. He had let me know he was not going to make it. Lynn McAllister. Quinn Pauley.
Here.
Thank you. Katrina Peters.
Here.
Thank you. Chuck Podesta.
Here.
Thank you. Dr. Mark Rosenberg. Dr. Jonathan Salinas.
Here.
Thank you. Dr. Villas Sastry. Andrew Topper.
Here.
Thank you. Dr. Darla Zarli.
Here.
Thank you. And Lei Zhang.
I'm here.
Great, thank you. All right, and I just want to go through our ex officio members really quick. We have Sandy Rubelin.
I'm here.
Thank you. Shelley Aguilar.
Good morning, I'm here.
Good morning, thank you. Lisa Latrice.
Here.
Thank you. Dr. Furman Ligon.
Here.
Thank you. Cody Finney.
Here.
Thanks. Scott Kipper.
Here.
Thank you. Russell Cook.
Present.
And so, oh, sorry, Russell, are you here?
I am here. Yes, sorry. I
Perfect.
had trouble getting my mute button. Thank you.
No worries. Thank you. And Celestina Glover.
I'm here.
Great. Thank you so much. All right. At this time, I just want to check with Angelica. Can you please confirm if we have quorum?
We have met quorum.
Perfect. Thank you so much. All right. And really quickly, I do see a hand raised, so I want to recognize Michael Gagnon. Do you have a comment?
Just that a couple of other people joined since you started the roll call, including Lynn McAllister and perhaps other voting members.
Perfect. Thank you for the reminder. I'll go ahead and go back through. Just really quickly, Dr. Eddie Ableser, have you joined? Okay. Lynn McAllister.
Yes, here.
Thank you so much. Dr. Mark Rosenberg.
Here.
Perfect. And Dr. Villas Sastry. Okay, perfect. We'll move on to agenda item 3. So agenda item 3 is review and approve the meeting minutes from the previous meeting that was held on March 7th, 2024. And I apologize to the members that I did send this draft copy with a little to no time to review. But we did get a few revisions already. So the letterhead, we needed to update that. And then also we have to mark Dr. Furman-Lagen is present during that meeting. So we will go ahead and take care of that. And I did want to let all the members know that that is not the norm. We will intend to get the meeting minutes to you with much more time to review in the future. And Dr. Polly, you have your hand raised?
Yeah, just my last name was spelled incorrectly.
Oh, thank you so much for that. We will go ahead and fix that as well. All right. Any other revisions noted by the group? Let's see, we have Lei Zhang. Lei, please go ahead.
Yeah, I just want to say is I also present at the first meeting as well.
Oh, thank you.
Okay.
Okay, perfect. I will add that in there.
Thank you.
And Celestina?
Yeah, just to let you know, my first name is spelled incorrectly.
Okay, perfect. I will fix that. I'm so sorry, you guys. I'll get those fixed and we'll have it moving on for the next one. Okay. At this time, I will entertain a motion to approve the March 7th meeting minutes with those corrections.
Lynn McAllister, motion?
Thank you. Do we have a second?
I'll second.
Sarah.
Oh, I'm sorry. Who was that would second? I didn't see you.
Michael seconded.
Okay, perfect. Thank you. Okay, we have a motion and a second. Any discussion? All right, all in favor, please say aye. Oh, I'm sorry. Before we do that, Katrina Peters.
I just want to note for the record that I'd like to abstain from the vote, given I wasn't present at the meeting at the time.
Great, thank you. All right, all in favor, please say aye.
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 All opposed? Okay, motion passes. All right, now we'll move on to agenda item number 4, which is public comment. No action may be taken upon a matter raised under public comment period unless the matter itself has been specifically included on an agenda as an action item. Due to time considerations, the period for public comment by each speaker or organization may be limited to 3 minutes, and speakers are urged to avoid repetition of comments made by previous speakers. If you would like to provide public comment at this time, please raise your hand utilizing the Teams platform, or if you are calling in, please press *5 to raise your hand. And I would like to call for any public comment. Okay, seeing none, we will go ahead and move on to agenda item number 5. This is discussion of part 1 of the draft regulations. So for this, I just wanted to frame this discussion as just that. It is a discussion. This will be the first opportunity for this group to review some draft language on what might be included in these draft regulations pertaining to the requirements that are outlined through Assembly Bill 7 of the 2023 legislature. The premise for these proposed revisions is based primarily on 3 things: reviewing the specific requirements of AB 7, particularly Section 1.08. Number 2 is reviewing the regulations already developed pursuant to NRS 439.589 governing health information exchanges. And number 3 is proposing draft language looking to encompass AB 7 requirements in alignment with the needs of the state and the timeliness documented throughout the bill. So for this discussion, we will go section by section of the document with any proposed draft regulation revisions and solicit feedback from the members. Again, this is the first introduction to these draft regulations, and I want to give you all a chance to digest it. If members have specific comments on particular sections as we go through the document, I will give you all a chance to raise your hand and I will call on you to provide your comments. We do not want to get into debates or lengthy back and forth with the feedback. So if members would like to provide written feedback on particular sections following today's meeting, you are more than welcome to by emailing me directly. So I'm going to share my screen. I got to find you all again. Oh, I'm sorry. And then we have a hand raised from our DAG, Gabriel. Gabe, please go ahead.
Yeah, just to piggyback on what you were saying there, this particular item is not agendized as an action item today, so we will not be having any votes or motions or things of that nature today. We specifically will not be requesting that, for example, you all indicate consensus on one particular item because you will be given the opportunity to do that at a future meeting. What we're instead seeking is just sort of feedback, general, whether you like something or whether you clearly don't like something, or whether you'd like something, an alternative to one of these at a future meeting. Those types of comments are appropriate, and you can make those either now or in writing before the next meeting. And at some point, you will be given an opportunity to vote your approval or recommendations of either these or different suggestions for the various draft regulations.
Perfect. Thank you so much, Gabe. Appreciate that. So these draft regulations you see before you, this is going to be a working document. So we will use this information gathered from today's discussion to inform further revisions, additions, or deletions to these draft regulation language to put forward for further discussion and action during our May meeting. So the May meeting will be where we will add specific action items on the draft language for members to vote upon. We will plan on naming each version of the draft language so we don't lose that historical context or language as this discussion and the regulation language itself evolves. So using a similar formatting style as I shared with you all previously, any suggested deletions will be shown in red strike-through text, and any suggested additions will be shown in blue italics text. Because AB 7 calls out in section 1.08 of the bill that these regulations are to be expanded to include not only health information exchanges, but more broadly, the maintenance, transmittal, and exchange of health-related information, we first proposed to change the title of these regulations as such. So I just wanted to note here that the title, we included the maintenance, transmittal, and exchange of health information. So are there any initial comments on this first proposal? And please feel free to raise your hand and I'll call on you. All right, seeing none, we'll move down. Sorry for the scrolling. So secondly, due to language proposed further in the regulations, we propose the following definitions to be added. We'll first go through each definition here, and then I'll ask for any feedback on this whole section. So first we have interoperability. Before I say, oh, Lay, did you want to go ahead? I saw your hand raised.
Only thing is on the line 5, the QHINTS, the interoperability of a qualified health information network prescribed by office or ONC. I think we should change to designated by ONC. Currently, they have 7. The QHINTS network are designated by the ONC. So that's.
Thank you, Lay. I will add that in, but I just ask that if everybody could hold all comments until the end, we'll review these definitions first, and then we'll go through comments. Thank you.
Thank you.
Okay, so interoperability. Suggested definition is that interoperability means the ability to securely exchange electronic health information with electronic health information in other networks and technologies used to maintain, transmit, and exchange health information in compliance with applicable HIPAA standards and in accordance with the applicable standards for the interoperability of qualified health information networks prescribed by the Office of the National Coordinator for Health Information Technology of the United States Department of Health and Human Services. And the justification here is that interoperability is cited several times throughout the bill, and due to subsequent requirements in the bill, a regulations definition here is warranted. Next, we have provider of healthcare. The suggested definition is for a provider of healthcare to have the meaning ascribed to it in NRS 629.031. So the justification here again is linked to the language and requirements set forth in the bill. And then lastly, we have electronic health record system. The suggested definition is that an electronic health record system means technology with the ability to securely maintain, transmit, and exchange electronic health information that make protected health information available instantly and securely to authorized users. The justification on this one is that the bill requires, unless otherwise exempted, the department and the divisions thereof, other state and local government entities, healthcare providers, third parties, pharmacy benefit managers, and other entities licensed or certified pursuant to Title 57 of NRS to maintain, transmit, and exchange health information. So one way in which to meet this requirement is via an electronic health record system, thereby warranting a definition. So given these definitions, would like to pause here for comment and feedback. Please feel free to raise your hand and I will go ahead and call on you. So first I see we have Michael Gagnon. Please go ahead.
Yeah, thanks, Melinda. There are several applicable standards for interoperability that are not specifically about qualified health information networks. That's a level of interoperability that's kind of at a national scale. But there's also other interoperability standards around things like the Medicare conditions of participation alerting that has to happen, and that's not required of a QHIN at this point. So I think we need to change this a bit to identify the applicable ONC standards, and then add on that another part of this is the QHIN networks. So it's not just the QHIN standards that we should be looking at for interoperability. I can propose something if you're interested as a slight alternative offline if you would like.
Yeah, I would appreciate that, Michael. Thank you. I appreciate your
Okay.
comment.
I'll take a look at it. Thank you.
Sounds good. Thank you. All right, next we have Lynn McAllister. Please go ahead.
Yes, thank you. I just want to reiterate Michael's comment, agreeing with that. By putting in the specific QHIN part, we're pushing towards one part of it and not just going at the overall of what the ONC is doing for interoperability and exchange. So I look forward to that language that Michael is going to propose.
Great, thank you, Lynn. I appreciate that. All right. Any other comments on these three proposed definitions? Okay, we'll move down. Oh, go ahead, Michael. Did you have something?
Actually, do you mentioned later certified EHR technology around electronic health record systems? Is that important here in this definition? Do people think?
I'm not sure. What would we be getting at if we said certified health information technology?
Well, the certified implies a certain ability to securely maintain, transmit, and exchange, like it defines some of the standards they have to follow. Like more recently, they have to follow this standard called FHIR, F-H-I-R, for an API. And so I just wondered if we wanted to put in this definition that it should be a certified electronic health record system, not just broader.
I see. Does that have to do with the ONC certification at all, or?
Yes.
Okay.
Yeah. And so, maybe it isn't required here. We're just defining what an EHR is. And then later on, we say, something else that says, no, you should be using certified EHR to do that. But I just wondered what the group thinks about, that.
Are there any comments from the group on that proposal thought? Michael, I see you have your hand raised. Do you want to go ahead?
Michael.
Yep. I was just going to say, I mean, I definitely like that suggestion, but then we maybe have to link to somewhere what certifications we're willing to accept.
Mm-hmm. Okay. Thank you. Just taking notes. Okay. Now we'll move on down here. Okay, so next we have our first section of the regulations with a proposed title to note requirements concerning the electronic maintenance, transmittal, and exchange of electronic health records, prescriptions, health-related information, and electronic signatures. Because the regulations prescribed by the bill are intended to more broadly focus on the electronic maintenance, transmittal, and exchange of electronic health information and signatures, rather than narrowly on health information exchanges, we propose the renaming of this section. Further here, you will note that the numbering changes from the original language with the addition in section 1A that a health information exchange that operates in this state must be a member of the Trusted Exchange Framework and Common Agreement developed under section 3001 C9B of the Public Health Service Act in the Federal Register prescribed by the Office of the National Coordinator for Health Information Technology of the United States Department of Health and Human Services. The reasoning for this language is due to alignment with the nationally recognized best practices for maintaining, transmitting, and exchanging health information electronically. And then really quickly, because it is all in the same section, I'm just going to scroll down here to the last little bit of this section. So here you will note the addition that a health information exchange that operates in this state must operate a secure exchange network in which healthcare providers and other authorized users can share information from different electronic health record systems and comply with the reporting and audit requirements of NAC 439.586 in sections 1I and J here respectively. So here I would like to pause for comment or feedback from the members. Please feel free to raise your hand if you have specific comments on this language. And Michael Gagnon, please go ahead.
One of the things I did not note in this section was it does not say that the HIE should manage patient consent. And I think due to the informed consent and effectively, the terms used opt-in law in the statute, we may want to say that that's something they have to be able to do. Other thoughts?
Any other thoughts from other members on that? Jerry Reeves, I see you have your hand raised.
Yes, I think that you reference in paragraph A or state law, and I believe that state law requires opt-in consent. So if you're going to refer to state law as well as federal, then I believe that the requirement for consent is necessary, and I don't believe that QHINs require opt-in patient consent.
Thank you for that, Jerry. Okay.
Yeah, I think that probably does cover it if you saying you have to follow state law and regulations adopted pursuant there too, because that is the state law.
Okay, perfect. Let's see. And then for this, is there a specific area that we should maybe put that management in there, or would anyone like to try and provide draft language?
Unless we wanted to break out separately the privacy and security requirements under state law, that might be a way to draw more attention to that, as opposed to kind of the applicable requirements of high tech and such. But I think it probably is covered.
Okay, I'll move down to the next section then. Okay, so here we've added an entirely new subsection to this main. Oh, sorry, is there a comment?
Yeah, one more thing. In H, in the section above, it says holds a nationally recognized accreditation. And I think mostly right now, those accreditations are around privacy and security, not so much around information exchange themselves. Other than QHINs, there are no other accreditations for health information exchange, and a tremendous amount of exchange happens that is not a function of a QHIN, event notification, and several other things. So I might consider putting recognized privacy and security accreditation. That's what has been typically in the past the certification requirement by the state to hold a privacy and security accreditation.
So here, privacy and security. Accreditation.
Yeah, because there definitely are those. There's ENAC and there's high trust and such. And those are really important, to ensure privacy and security.
Okay. Any comments on that? Okay. All right, so here, our new subsection. So here again, because we are more broadly focused, we are looking for an electronic health record system as prescribed in this section, must be certified. So there's your certification, Michael, by the Office of the National Coordinator for Health Information Technology of the United States Department of Health and Human Services, thereby maintaining interoperability and allowing patients to access electronic health records directly from the healthcare provider of the patient and forward such electronic health records electronically to other persons and entities, allow for the electronic transmission of prior authorizations for prescription medication, ensure compliance with the requirements, specifications, and protocols for exchanging, securing, and disclosing electronic health records, health-related information, and related data prescribed pursuant to the provisions of the Health Information Technology for Economic and Clinical Health Act, 42 United States Code, Section 300JJ, and 17901, the Health Insurance Portability and Accountability Act of 1996, Public Law 104-191, and other applicable federal and state law, and be based on nationally recognized best practices for maintaining, transmitting, and exchanging health information electronically. So the justification here is being that this requirement is in alignment with nationally recognized best practices for maintaining, transmitting, and exchanging health information electronically, and does tie back to the bill in section 1.08, specifically subsection 1. So again, here I'd like to pause and ask if there are comments from the group by raising your hand. Okay, seeing no comments, we will go ahead and move on. Okay, so next we again have entirely added a new subsection to this more broadly focused area. And this section is meant to provide that except as otherwise provided in subsections X, X, and X, because those are the exemptions that are outlined in the bill to be codified. So I don't have those exact subsections yet. But further, that hospitals and physician group practices with more than 20 employees must comply with the provisions of subsection X of NRS 439.589 on or before July 1st, 2024. The department and the divisions thereof, other state and local government entities, providers of healthcare, third parties, pharmacy benefit managers, and other entities licensed or certified pursuant to Title 57 of NRS operating in this state must comply with the provisions of subsection X of NRS 439.589 on or before July 1st, 2025. And physician group practices or other business entities organized for the purpose of practicing a healthcare profession with 20 or fewer employees, including without limitation sole proprietorships, must comply with the provisions of subsection X of NRS 439.589 on or before January 1st of 2030. So the justification for this subsection is related to specific requirements outlined in the bill in section 2.8 that talks to those timelines. So again, want to pause for comments or feedback from the group by raising your hand. Michael Gagnon, please go ahead.
Sorry, I'm on mute. This is the section that said you must share data electronically, right? That's the reference in this.
Yes, and then the line in item 3 there is noting the exceptions to that. So, you know,
Right.
as we get like the further down, I'll show you what those are.
Okay, I get confused by some of the references to the sections along the way, and
I know, yeah.
Thank you.
Yeah, thank you. Okay. So then lastly, in this broader focus section, we've added an entirely new subsection that provides that compliance with the provisions of subsection X, meaning the requirement to electronically exchange health information, is satisfied by either of the following. Either maintaining an electronic health record system pursuant to NAC 439-586 subsection 2, or maintain connection with a health information exchange pursuant to NAC 439.586 subsection 1. The intent here is to allow for providers of healthcare to meet the requirements as outlined in the bill by either connection with an electronic health record system or a health information exchange. So again, I'd like to pause for comments from the group by raising your hand. And Michael Gagnon, please go ahead.
Yeah, a couple of comments on this one. Should we say a certified health information exchange, since we've defined those, you know, in AB7, so that not just any, but one that's been certified by the state? I think that would be a good add. And then you know, and this, it feels to me like this is the easy button. You've complied with exchange of data if you do these, right? So that's a good thing. But I think it may be, instead of saying or A and B, it should be and A and B. Because just having an electronic health record does not necessarily mean it's interoperable. And if we're, you know, and there are other ways to do it. I would say, you know, you don't have to join a health information exchange because that's very specific in AB7 as well. But it is, but you can claim, it's kind of like we did with meaningful use. If you do the following things, you can say, you've definitely checked the box. This would be a similar thing. If you have a certified EHR and you're on a health information exchange, you comply completely, you know what I mean? And that, again, I'm not excluding that there's other ways to do that, but I would recommend thinking about changing the word or to and put certified health information exchange. Other thoughts?
Yeah, thank you for that. On this section, I was under the impression that if you have a certified electronic health record system, so meaning the ONC is certified, right? That means that you have an interoperable electronic health record that is able to exchange information.
It not quite. Is that, you know, it may be capable of doing it, but the steps you have to take and often fees you have to pay to make that happen. So just having a system is not enough. You know, there's interoperability requirements that the vendor lays on, or interface requirements and such. And so, again, like I said, there's other ways to do it. But by connecting to an HIE, you clearly are, you know, and you follow the specifications of the information exchange, but not necessarily just by having an EHR. Now, a certified EHR is required to have some way to do it, but it doesn't mean you automatically are doing it.
So
Do others who have electronic health records follow that or understand what I'm saying and agree?
That does make sense, Michael. I just want to quickly clarify, because we have this section up here that does define that an electronic health record system prescribed in this section, meaning the one that you have to comply with, must be certified. It must allow for the electronic transmission and all that. Does that not meet the need of the interoperability portion? Like, should we add more information here that speaks to interoperability?
Yeah, allowing for it and doing it. My point is we need to, if we say, if we put it in here, fine. You know what I mean? And you actually implement the standards for, and capabilities for exchange, then yes, I think then it would meet the requirement.
Okay, thank you. Open to other members' comments. So I do see Chuck Podesta, please go ahead.
Yes, thank you. Yeah, just to add to Mike, give it a little clarity from an EHR perspective. He is correct. I'll give you an example. For Renown, we have Epic as our electronic health record, right? And within there's a product called Care Everywhere, which is basically an internal HIE within Epic customers. So if I were to have an episode of care at Renown, and then I went to Southern California and went to some organization there that had Epic as well, we wouldn't necessarily have to go through an HIE to share information, because it's two Epic electronic health records, both certified certainly. But if that organization decided not to opt in to the Epic Care Everywhere product, then we would not share information that way. We would actually have to go through some sort of HIE. So Mike is correct. It's not mandated by the EHRs to share information. Most of them do, because it makes sense for better patient care, certainly. But they don't have to. There's no requirement. So I just want to add that color.
Great, thank you. I appreciate that. Jerry Reeves, please go ahead.
I guess the question would be whether a health information exchange is defined somewhere in this document or not, and would that be another way to address the issue of and versus or with the health information exchange? If health information exchange is defined and there's a nationally recognized definition of health information exchange, that might be another way to address this issue of and versus or.
Sure, thank you. I appreciate that. I do want to note as well, we do have language in the bill itself that specifically calls out that the regulations must not require anyone to connect to an HIE, which is kind of, I mean, you were talking about interoperability, and an HIE is basically, giving you that avenue, but our regulations cannot require someone to connect to an HIE. So we do have that stipulation to work around.
Linda, isn't the definition of the HIE in the statute? So we don't need it in this regulation. That's why it's not here?
It could be. I'm not sure. I'd have to follow up on that.
I think it is, but we'll follow up on that too. We should definitely, and I don't think anyone's saying that it's a requirement to join an HIE. That's clearly in the statute that you're not, but that if you do, you meet the requirements of exchange, right? That's what you're getting at by that.
Yes.
Yeah. Okay.
Exactly.
Yeah.
Yeah. Okay. Okay. So we will move down. So I apologize for the scrolling, because we're going to skip through the language already here in this chapter of regulations and move into the next section here. So 439.584, duty of exchange to limit access to exchange, compliance with policies and procedures of exchange, creation, maintenance, or transmission of prescription using exchange. So subsection 1A is revised to read, a health information exchange shall, except when use or disclosure of protected health information is permitted or required by federal law for treatment, healthcare operations or otherwise, and except as otherwise directed by the patient, ensure that only covered entities with which the Health Information Exchange has entered into a business associate agreement, as described in NAC 439.588, and members of the workforces, contractors, and agents of such covered entities who have a legitimate need to use the Health Information Exchange are allowed to use the Health Information Exchange. So the broad intent here is to, again, align with federal law and maintain patient confidentiality. So I'd like to pause for comments from the group. Michael Gagnon, please go ahead. Oh, you're on mute.
Thank you. First, it doesn't say all the HIPAA required things. So it's treatment, payment, or healthcare operations, and it does say or otherwise, which might be enough to include other things in there. But also, I wonder if it's just covered entities going forward. More and more exchanges are considering under certain state policies and other governance kind of requirements, sharing with social service agencies and such, and governmental agencies. And I wondered if covered entities is just too narrow as a concept going forward. Because it isn't just, and obviously patients can direct it, and you do say that here, otherwise directed by the patient clearly. And that would require an authorization to do that. But just some thoughts from the group about, is covered entities now too narrow a definition?
So, Lei Zhang, I see you have your hand raised.
Add the more on top of the Michael. This one is a previous section. We have one section, C, support public health and population health initiatives. I wonder at here, does public health agency is under covered entity? Does public health agency can access health exchange information from here?
So you're saying a public health agency is a covered entity?
No.
No, it's not a covered entity.
No, it's not, but it is defined often in law. But I also wonder if we shouldn't, there's a push nationwide to broaden the concepts to also include care coordination, population health, and public health. I wonder if we might add payment, care coordination, population health, and public health specifically after healthcare operations. To just be clear about those things.
Sure, I'd be open to that suggestion if you want to provide that draft to me. I also see Lei, you have your hand raised again. Please go ahead.
Sorry, I should lower my hand.
Oh, okay. Yeah.
Yeah,
No
I
worries.
forget lower my hand. It's only saying if public health agency is not covered entity, how can we support the public health and population health initiative? So that's the only thing. We need to tweak the language a little bit.
I see what you're saying. Okay.
Yeah.
All right. And then Jerry, please go ahead.
Yes, there is a lot of work that is necessary and beneficial of community-based care coordination activities. And so I support Michael's comment that we include public health and care coordination activities because especially for high social needs populations, there is considerable requirement and need to share some clinical information that the patients consent to with the social service entities because social determinants of health are such a major cause of adverse health outcomes.
I just put in the chat some other things I think we might want to consider adding to this after healthcare operations. So it's just adding payment, care coordination, population health, and public health.
Perfect. I will add that in as, here it is, right here, right? Healthcare
Yes.
operations.
And it's all under federal or state law, so like it's, you know, it would have, it's just clearer definition of those things.
All right, any other comments from the group? Okay, we'll move down. Sorry for the scrolling. Okay, so NAC 439.588, the prohibited use, retrieval, or disclosure of health information using exchange, compliance with certain federal and state laws concerning electronic information. Subsection 1 is revised to read, except when use or disclosure of protected health information is permitted or required by federal law for treatment, healthcare operations, or otherwise, and except as otherwise directed by the patient, a person shall not use, retrieve, or disclose more health information using a health information exchange than is necessary to accomplish the purpose of the use, retrieval, or disclosure. So again, looking to, would we then insert that same language in after healthcare operations? Looking to comments from the group. Michael, please go ahead.
The term typically used is minimum necessary. Should we just incorporate that in here somehow?
Right. Yeah, I'm not sure how to do that, but I'm going to make some notes.
We'll have to, it might have to be rewritten to make that, but I think that's the federally recognized term under HIPAA.
Yeah. Any other comments from the group on that? Lay, please go ahead.
Talk about minimum necessary is item 3 is already covered that one. One person shall retrieve those things is inconsistent with HIPAA.
I got a different problem with that one.
Okay.
All right.
Okay, can I ask a question about how do we define person? Because if person also means an individual or a citizen or a patient,
Mm-hmm.
then some of this kind of isn't right. Because you don't know, you know, a citizen is not signing a business associate agreement even to view their own information, right? And so maybe a different definition. I get the reasons for it all if person was an organization or a healthcare entity, but and when it actually becomes a real person, then it kind of some of it doesn't work as well anymore in terms of this language.
Interesting thought. Sarah, I see you have your hand raised. Please go ahead.
Yes, I just wanted to say, and I'm trying to pull it up, because NRS Chapter 0 actually has definitions, and I think it defines person. And so I do think this is probably a good, a good clarification, meaning if we want to use a special definition, we probably should, because I think the default, unless it's defined elsewhere in 439, which maybe, I don't know, but I know person, I just pulled it up. Person defined in general unless it's defined differently, it means natural person, any form of business or social organization, and then non-government entities.
Yeah.
So we probably want to clarify if we don't want to use that, and it's NRS 0.039 is the default definition.
Yeah, because then it would include people, and people can't really comply with the BIA part of this and such.
Yeah.
The rest of them can, you know what I mean? The rest of those parts of that definition certainly do.
Yeah, so it sounds like we may need to add another definition for person.
Or not use person here, use the organizational part of it. But or exclude individuals, a person, but not including individual, something that makes it allowable for an individual to do all of these things. They have, many rights under the Cures Act for all access to their own information electronically and non-electronically.
Chuck, please go ahead.
Sure, thanks. Yeah, I think the way to do this, maybe use the same if you're going to expand the language for covered entity in the previous conversation, maybe use whatever that language is, whether it's, public health, all those different organizations, because those would all have the BAA. So keep that language consistent, separate the person out as Mike and others are talking about, but keep the language from the previous conversation. So we don't have two different explanations or two different descriptions, I guess is the best way to put it, if that makes sense.
Yeah, good point. Thank you. Lynn McAllister?
Yeah, we did put the definition at the beginning, provider of healthcare. That's a newly added definition, so potentially that could be included here instead of person.
Thank you, Lynn. Jerry, I see you have your hand raised. Oh, you're on mute, Jerry. Or I can't hear you. I don't know if anybody else can. Oh, it's weird. It shows you as not being on mute, but I can't hear anything. Is anybody else getting Jerry? No?
No.
Shoot. Jerry, if you can feel free to enter your comments in the chat if you would like. Or you can email me after the meeting as well, if that works.
We heard him before, but not now.
I know, crazy. All right. Any other comments on this section? Okay. We'll move on. Okay, we're skipping down towards the end. All right, so at the end, we have an entirely new section proposed here titled Request for Waiver of Requirements, and this is per NRS 439.589. So a provider may request a waiver of the requirements of NRS 439.581 to 439.595 inclusive and NAC 439.572 to 439.596 inclusive pursuant to subsection X of NRS 439.589, which request must include a written statement signed by the provider of healthcare certifying that the provider of healthcare satisfies the criteria set forth in subsection X of NRS 439.589 or other appropriate documentation that satisfies the department that such criteria is satisfied. The department will consider each request for such a waiver on a case-by-case basis and render a determination in writing. The provider of healthcare requesting the waiver may appeal the determination pursuant to the requirements of NAC 439.346. Justification here is related to the requirements as outlined specifically in the bill in section 1.08, subsection 6. So again, I would like to pause for comment or feedback on this language. Okay, and seeing none, I will go ahead and move on to the last section that we have here. So this is again an entirely new section proposed titled Inapplicability of Certain Provisions. The provisions of NRS 439.581 to 439.595 inclusive and NAC 439.572 to 439.596 inclusive do not apply to the federal government and employees thereof, a provider of health coverage for federal employees, a provider of health coverage that is subject to the Employee Retirement Income Security Act of 1974, a Taft-Hartley trust formed pursuant to 29 United States Code, or the Nevada Department of Corrections. So justification for this section is related to the requirements as outlined in the bill, section 1.08, specifically subsections 5 and 7. So again, I want to pause here for comment. Michael Gagnon, please go ahead. Oh, you're on mute.
Every time it's cost me $1 when I go on speaking on mute. Now, I wanted to ask about the section before, actually, and that is what's being said here is that a written statement signed by the provider, basically says that they are meeting the requirements for the exchange of information. Is that generally what this is saying?
Maybe. This one is more saying that the provider is proposing or asking for a waiver to the requirements that they exchange health information electronically as outlined in the bill, because there are certain provisions in the bill that say that, if you're a provider of healthcare who for chance doesn't have access to the internet or, something like that, they can propose for a waiver to meet these requirements that they exchange health information electronically.
So this is not saying that they do comply, but that a waiver if they do not. How do we say that they do satisfy the requirement, I guess, is what, what I mean? Because there's the opposite side of that. And could that be met by the health information exchange saying, yes, they've met all the specs for doing everything that, met our policies or met our specifications for how to do this. It almost, I read it the opposite way, which is probably wrong, but it says which requests must include a written statement of the provider that they are satisfying the criteria set forth. But are those criteria for exclusion or are those criteria for inclusion?
Right. So these here are the criteria for exclusion.
Okay.
We do not define how they would satisfy the requirement. So that would be something for the group to consider.
Yeah, maybe the group should consider how do we ensure that they are compliant. I would think I think more people will want to comply than will try not to comply, right? And so is there a way to do that?
Thank you for that. Jerry, please go ahead. If you can. Nope. I can't hear you.
Still no.
Cute. Let's see. I do see in the chat, Jerry, that you wrote consider entity instead of person on that other discussion that we had. Any comments on that from the group?
We might have to define entity then, and it probably goes back to the original language to exclude everything other than the naturalized person or whatever it said, but it's a new definition.
Let's see, I just want to go back here. Are there any comments from the group on this section here? Okay. So seeing none, we have reached the end of the document that has all of the, round one of proposed language changes here. So again, I would ask if you have any comments or feedback or perhaps draft language that you would like to propose that we can discuss at our May meeting, please email that to me directly. And I'll be sure that that gets into our May meeting. And again, during May, we will be asking for action items from the group on the language. So please be prepared for that. And I will do my absolute best to get you a copy of the draft regulations language that we will be discussing in May with enough time to review so that you can come to the meeting prepared. And I do see Gabe, you have your hand raised. Please go ahead.
Yeah, just once again, just as you're stating, if anybody has additional suggestions, obviously feel free to submit those. Those will be helpful. Just if you missed it now, you didn't miss it forever. You still have time to make those suggestions. And then I also wanted to say that we've gone over these that are here. Obviously, if there's other things that you think were not here, but that you were hoping that you felt should have been here, you can have those suggestions as well. Thank you.
Thank you, Gabe. All right. So at this point, we're going to be closing out agenda item number 5, and we'll move on to agenda item number 6 for public comment. So again, no action may be taken upon a matter raised under public comment unless the matter itself has been specifically included on an agenda as an action item. Comments will be limited to 3 minutes per person. Persons making comment will be asked to begin by stating their name for the record and to spell their last name and provide us with any written comments. So if you would like to provide public comment, please raise your hand utilizing the Teams platform, or if you are calling in, please press *5 to raise your hand. And I'll pause now for public comment. Michael Gagnon, please go ahead.
This time I remembered to get myself off of mute. The one public comment, and for the whole group to consider, is that as part of the recently passed Labor H bill, there is some language in there defining an organization they call a health data utility, and I don't mean to bring up a new term, but it's very similar to the concept of the contracted HIE in AB 7. If it is, if there's interest, there's the first line of that new federal regulation says the committee urges CDC to encourage states to coordinate with ONC to designate existing neutral, trusted, and nonprofit health information exchanges to be the state's health data utility. And then it goes on to further definition. And I just wonder if that might be able to become a concept that this advisory group reviews and considers.
Thank you for your public comment, Michael. Any other public comment? All right, then we'll move on to agenda item number 7, adjournment. So thank you everyone for your time today. Really appreciate the discussion. And again, please feel free to reach out to me directly should you have any comments, questions, concerns. Thanks and have a great day.
Thank you. Bye now. Thank you.